Cervical myelopathy. As you know, the neck plays a very important role in our body. For example, the functions of the neck for flexion, extension, lateral bending, rotation, all these movements actually take place through the cervical spine. And the spinal cord is running from the cervical spine, then it goes into the thoracic as well as the lumbar spine. So if there's any problem with the cervical vertebra, cervical facet joints, or any problem with the different ligaments which is surrounding the cervical spine, this can directly affect the spinal cord and eventually can lead to cervical myelopathy. By definition, cervical myelopathy is actually the degenerative disease of the spinal cord which may lead to the gait disturbances as well as the upper motor neuron symptoms like clumsiness of the hand as well. If you look at the anatomy, this is a C2 cervical vertebra. In the C3, then C1 and C2, as you know, they are the supraaxial spine, and from C3 below, they form the subaxial spine. There are certain ligaments which are attached to this cervical spine. Anteriorly, we have anterior longitudinal ligament. Posteriorly, we have a posterior longitudinal ligament. Then we have a spinal cord, and then between the lamina and transverse processes, we have spinolaminar ligaments, which may include ligament of flavum, interspinous ligament, paraspinal. Other ligaments are always present as well. Now, if you see it over here, problem could be anywhere, right from anterior to the middle facet and to the posterior as well. And you know, the spine is actually divided into three columns. There is an anterior column which forms the anterior 2/3 plus the anterior longitudinal ligament of the vertebral body. Then the posterior 1/3 and posterior longitudinal ligament form the middle column, and all other spinolaminar ligaments as well as the transverse process and spinous processes of the vertebra form the posterior column. So if the problem, whether it's anterior, middle, or posterior, it gonna narrow the spinal cord, or spinal cord will get affected and would result in cervical myelopathy. So as you know, this dura, which is actually acting in the posteriorly, then there is in between, you have three layers of there's a dural layer, then there's a subarachnoid space as well as the pyometer, which is present inside as well. Then there is a CSF, which is actually just between the dura and the arachnoid space. And you can appreciate that there's a posterior longitudinal ligament, which is coming right below over this level. Then posterior, in the posterior column, we have a ligamentum flavum, which is actually interspinous ligament, and this can hypertrophy to create problems for us. And this is the spinal cord. You can appreciate the teething in the spinal cord compression which is occurring over here. Now if you look closely, there is definitely a problem with the disc bulge as well. There is some translation of C4 anteriorly as compared to C3. There may be the hypertrophy, or for example thickening of the posterior longitudinal ligament. There may be hypertrophy of ligamentum flavum, or this may be associated with the dissociation of posterior longitudinal ligament from the vertebra and compressing it over the spinal cord. There may be ossification or calcification of ligamentum flavum. There may be ossification or hypertrophy of posterior longitudinal ligament, or there may be increase in anterior posterior vertebral body length. For example, due to any traumatic cause, the one vertebra is translated as compared to the other. This will actually result in a tenting of the spinal cord and may lead to compression. So to understand cervical myelopathy, one needs to understand that the problem could be in the anterior, middle, or posterior column. There could be problem with the ligaments such as hypertrophic ligaments. There could be problem with the degenerative vertebral bodies, for example formation of bony spurs, ossifies may impinge on the spinal cord, or may there be degeneration of facet joints as well. As a result, there may be compression and decreased spinal cord volume, and this may lead to spinal cord stenosis and production of symptoms, a cluster of symptoms which actually called as cervical myelopathy. As I told you, there could be osteophytes compressing over there. There could be loss of vertebral body height, and this happens usually when there is a degeneration or old age, osteoporosis develops. The collapse of the vertebral body leads to decrease spinal canal volume. Or there may be other causes, as I told you, hypertrophy of posterior longitudinal ligament, or there may be an hourglass reshaping, especially in the old age There may be hypermobility and listhesis. Now, spondylolisthesis or hypermobility may be in the lumbar spine, or they may be associated with a traumatic event in which, for example, there was a flexion distraction injury in which the one vertebra has flexed and translated over the other body. This may lead to decreased spinal cord volume, and eventually the spinal cord damage which has occurred during the trauma will eventually progress to cervical myelopathy. Now coming to the causes, as I have almost told you, the causes are actually can further be divided by you can name the disease or you can name the disease processes. Most common cause is actually the degenerative cervical spondylosis. Cervical spondylosis is actually the degenerative disease of the cervical spine, in which there is actually loss of vertebral height, formation of bony spurs, there is arthritis of the facet joints. This actually all these bony spurs and osteophytes which are actually formed, they either narrow the volume of the canal or they actually impinge on the spinal cord, leading to eventually progress from cervical spondylosis to radiculopathy, and once the radiculopathy progresses, this may go into cervical myelopathy as well. And next one is congenital stenosis. This is usually a rare cause. Congenitally, there is a Pavlov ratio which is actually an AP and lateral diameter is calculated, and AP divided by the lateral diameter of the spinal cord is you calculate a Pavlov ratio. If it is normal value is 0.8, but congenitally the spine may be stenotic, or there may be very less space available for the spinal cord, and this may lead to cervical myelopathy at a very young age. Other causes is the ossification of posterior longitudinal ligament. As I just told you in the previous slide, that there is either anterior longitudinal ligament and then the posterior longitudinal ligament. Posterior longitudinal ligament is lying just anterior to the spinal cord, and this ossification, hypertrophy or calcification can actually impinge on the spinal cord, leading to myelopathic symptoms. Then there could be a mass which is producing a tumor. For example, if there is a mass which is present inside the spinal cord, this may grow and compress the spinal cord, leading to stenotic type of a pattern and eventually leading to myelopathy. Then there could be an epidural abscess. As in the previous diagram, you've seen the dura mater is actually covering the spinal cord. If there is epidural abscess which is actually compressing from outside, this may eventually lead to stenosis of the spinal cord, and symptoms may come up with cervical myelopathy. Then there is a trauma. Trauma is one of the very important causes, because usually if there is a flexion distraction, or there is compression injuries, or there could be a rotational injuries as well, in which there is actually a lot of ligaments are damaged, and there may be reduced joint space at a certain vertebral level. For example, if there was C6, C7 listhesis, there may be a reduced joint spinal cord space at the C6, C7 vertebra, and this is where the impingement of the nerves may occur, and eventually they may initially present with radiculopathy, which would eventually progress with myelopathic symptoms. Then there is a cervical kyphosis. As you know, our cervical spine is lordotic by posture, but if it becomes kyphotic, this would actually translate the vertebra anteriorly, and this would result in the posteriorly there would be decreased space available for the spinal cord. And if the kyphosis is occurring in multiple levels, this could be a problematic, because patient can present with multiple level disease of presenting with signs and symptoms of cervical myelopathy. The next is a neurological injury. This is also associated with trauma. Usually, sometimes the trauma only occurs and such that there is only bony injury or ligamentous injury, where this neurological injury may be spared. But sometimes there is a complete spinal cord injury, and when the cervical spine is injured, this may present with upper motor neuron lesions, leading to cervical myelopathic symptoms. Now coming to the clinical features. How would you see a patient with cervical myelopathy? One thing which you need to understand before moving on to the clinical features, that a lot of features overlap. For example, features of cervical spondylosis, some features overlap in radiculopathy as well as in myelopathy. And then there are certain features of radiculopathy which may overlap in myelopathy as well. It's actually a continuum of a single form of a disease, that there is degeneration which may press on a single nerve, leading to radiculopathy. may progress to multiple level disease and eventually presenting with upper motor neuron lesions and symptoms and clumsiness, hand and gait instability, causing cervical myelopathy. Now, before understanding the clinical features, you have to understand as it affects mainly the from C4 to C6 level. So mainly the symptoms are on the neck area. These include, for example, symptoms include neck pain and stiffness. This is one of the very common causes. This may occur in spondylosis as well as the radiculopathy as well. But what's important to know is that there's an axial neck pain and occipital headaches are very common. Now, you have to understand that there may be only sensory disturbances, for example, are maybe associated with muscular abnormalities as well. We'll be discussing the sensory as well as the muscles problems in the upcoming slides, and we will be discussing the different tests which we have to perform to differentiate exactly whether the myelopathy is present or not, or it's isolated cervical radiculopathy. Now, coming to the symptoms, other symptoms include the extremity paresthesias. For example, radiculopathy can present with this kind of a problem as well, but there may be diffuse non-dermatomal numbness and tingling. In radiculopathy, specific nerve was being impinged. As a result, there was specific pattern of if it was C6 involvement, then we were seeing that the paresthesias, pain, numbness was on the lateral side of the forearm as well as thumb and the index finger. But there the pattern could be non-dermatomal and may involve a diffuse type of numbness, and paresthesias may be present as well. Then the weakness and clumsiness. Usually the definition is that there is degenerative cervical disease with gait disturbances and clumsiness of the hand. So these are two very important myelopathic symptoms when then to label a patient with cervical myelopathy. Usually there is weakness of the muscles, especially of the upper limb, and there is a decreased manual dexterity. The patient complains of that it's been quite months that she's fumbling things from his or her hand. She's unable to eat properly. For example, in Japan, people use chopsticks. There's a lot of difficulty to eat from the chopsticks. And then there would maybe having a problem that, for example, she's dropping her change, she's dropping her jewelry off and on. As a result, she's unable to perform this intricate task which involve manual dexterity, which maybe have reduced over the period of time. Then there is this gait instability is always there. It may be associated with due to the causes of upper motor neuron lesions, or there may be a concomitant lumbar stenosis as well when we are talking about the cervical myelopathy. And patient feels unstable on the field. There may be they may have a problem with tipping off quite often, and there may be weakness walking up and down the stairs as well. And usually this very classical symptoms that there's weakness in the arms and the legs. He is unable to hold things in his hand as well as unable to walk properly on a straight line as well. Then urinary retention. Although this is a very rare symptom, and when this starts to happen, probably this disease has progressed quite a lot. And usually it appears very late. And it's not a very useful in diagnosis, but it needs, when this does appear, we need to differentiate it from cardiac venous syndrome, because this could be a surgical emergency if this urinary retention is associated with cardiac venous syndrome. Urinary retention with cervical myelopathy is rare, but if it does happen, then we have to deal with that as well. Now, whenever you have a person who appears with these kind of symptoms, for example, patients having neck pain, non-dermatomal dysesthesia, tingling sensation, then there may be fumbling of objects or the gait disturbances. If you suspect cervical myelopathy, then the first thing you need to look at is to get AP, lateral, oblique views of the cervical spine. And we need to get the flexion and extension views as well. And why we need to get flexion extension views is to look at the listhesis. For example, during the flexion, one vertebra may be translated anteriorly more as compared to the other one. So for an AP view and a lateral view, you usually see the general changes such as degenerative changes, ossified formation, facet joint degeneration would be there. There may be foraminal stenosis as well. And you may see on the lateral view as an ossification of posterior longitudinal ligament, or probably osteophyte formation. There may be osteoporosis as well. There are element of osteoporosis as well as anterior longitudinal ligament ossification as well. But usually on the oblique view, you need to make it sure that there is no facet joint degeneration, and usually the best view for to assess the facet joint degeneration is actually the oblique view. Then we have to get the flexion and extension views, and these are actually done to look at the listhesis. Now, once we've done with the x-rays, then the gold standard for diagnosis of cervical myelopathy is actually the MRI. MRI is gonna tell you a lot about things. For example, whether the spinal cord is there is stenosis of the spinal space available for the cord or not, where the problem is with the vertebra, whether the problem is the hypertrophy of the ligaments, or it is something which is from outside. There's a tumor and a mass which is compressing, like if there's an extradural abscess or not. All this will be actually the topic of discussion for the MRI. And when you look at the MRI, this is the view which is usually available: C2, C3, C4, C5, C6, C7. If you look closely at the C5, C6, C7, there is definitely loss of vertebral height. You cannot appreciate any disc as well, probably between the C5, C6 and C6, C7. This means there was definitely extrusion of the disc. There was spondylotic changes. There was degenerative changes as well. If you see clearly over here, this anterior ossified formation over here and over here as well. Then there is some thickening as well as hypertrophy of posterior longitudinal ligament over here. And if you see, there may be ligamentum flavum hypertrophy as well. And probably the spinal cord is being stenosed or impinged over at this level. So this is C2, 3, 4, 5, 6. C5, C6 is the most commonly would be affected. There may be affected C6, C7 as well. So this level is affected, as you know, by sensor distribution of C5 is around the shoulder regimental batch area and over the lateral aspect of the arm. For the C6, you have lateral aspect of the forearm, thumb, as well as the index finger. So patient would complain of that he or she is having a pain over this area as well, and she is feeling numb sometimes in the thumb or somewhere in the index finger as well, and sometimes she has paresthesias of the lateral aspect or radial aspect of the forearm. So by this you can go back and you can think of it that probably the problem is at the C5, C6 level. And if C6, C7 would be affected, the nerve which would be affected would be C7. And C7 usually actually supplies the middle part of the finger as well as the small strip area over the volar aspect of the forearm. And if there is numbness over these areas and dysthesias and paresthesias, then probably the C7 involvement is always there as well. So now this is actually when it's progressing. Now it can progress to move furthermore, or it can involve the upper segments as well, depending upon to what time the patient has actually presented. And sometimes multiple levels may be involved as well. So if this is the lateral x-ray, if you see it closely, this is the C2. You can appreciate how much the loss of this, there is a very less amount of sclerosis. This is probably in osteopenic or osteoporotic bones, which is actually there is loss of height as well. You can appreciate it over here in C3, C4, C5. There is definitely continuous hypertrophy and ossification of posterior longitudinal ligament. If you see anteriorly, there is some ossification of anterior longitudinal ligament as well as ossified formation as well. If you see it more closely, look at the disc exclusion over here as well. So therefore, probably the spine, if we get an MRI, the spine would be definitely compressed in this area. And this is why what happens in OPLL is our ossification of posterior longitudinal ligament is one of the very important causes of the cervical myelopathy. Now, if you're seeing another X-ray as well as the MRI in here as well. If you see X-ray, the gain, if you can appreciate, there is osteopenia, and definitely this is a patient with an age probably in 60s or 70s, osteoporotic male or female. And then you can appreciate as well, there's definitely, if you calculate the anterior longitudinal line coming like this, it's not exactly coming over it. So there is definitely some form of listhesis of C2 over C3 as well. There is a lot of ossified formation between C3, C4 and C5. as well as ossification of posterior longitudinal ligament as well somewhat. With you see it over here, there's definitely a lot of loss of facet joint space, and this may be leading due to the hypertrophic ligament of flavum, which may be impinging it from the on the nerve roots from the back, and the patient may have symptoms involving C3, C4 or C5 as well. If you see it over here, the spine is actually spinal cord has been compressed. One impingement is at this level, C3, C4. Then again you have C3, C5, and then C5, C6. You can involve it over here as well. Now the symptoms over here may be minimal, and patient may be only complaining initially of the dysthesias, paresthesias, the early radiculopathic symptoms. But if it goes on and it continues to progress, the usually progression is such that there is a slow progression. It progresses over 6 months to 1 year, maybe 2 years time. This slow progression, actually there is stepwise increase with the normal periods in between. So there is patient may be complaining of the patient was all back. Okay, there was problems like dysthesias, paresthesias for last 6 months, but suddenly now she is unable to hold everything with his or her hand. As a result, she is having problem with the muscle weakness. So this is a stepwise degradation which usually happens in the patient with cervical myelopathy. There are different classification systems. Once we get the CT and CT myelography is usually not done. But in case of a patient is an old age patient with a pacemaker in place, probably the MRI is not a good choice. Then you may have to go for a CT myelography or something with CT arthrography as well, so that you can assess the spinal cord anatomy and spinal cord space as well. There are different classification systems. For example, classification systems like you have a systems of Ranawat, you have system of Neuric classification system as well, and there is a Japanese Orthopaedic Association evaluation system. Cervical myelopathy is usually common over this Asian Pacific side, and that's why we have a specific Japan associated classification for this. Although multiple classification systems exist, but usually the Japan Orthopaedic Association evaluation system is more elaborative, and it's actually more concrete and involves multiple other systems, and therefore it's usually used to assess the patient for cervical myelopathy. There are different segments which are actually tested. For example, upper extremity, lower extremity, and gait disturbances, sensory function, urinary function. These all functions are actually assessed, and then they are scored over different points. And then we calculate the total points. If the total points are above 17, it's usually a safe point. But if they're below 17 points, this means patient is having a progressive myelopathy. And then you can assess it once the patient comes back after 2 months, 3 months, or 6 months. You can assess that, okay, whether its score is deteriorating and going down, or it's improving, or it's at static. So you can also assess whether how much the progression of the cervical myelopathy is occurring as well or not. You give 0 points if it's impossible to use either chopstick or spoon, because the manual dexterity is required for the chopstick to hold the chopstick first and then to pick up the rice and put it in your mouth. So manual dexterity is lost. This means usually you have 0 points. It's possible to eat with spoon but not with a chopstick. You give it 1 point to them. Possible to eat with chopstick but inadequately. That is where you can give 2 points. Possible to eat with chopstick, but patient is awkwardly eats with the chopstick. This is you give 3 points. And if the patient is normally as anybody can eat with a chopstick or spoon, then you give it actually 4 points. Actually, this upper extremity function is therefore it signifies the motor function or the manual dexterity function of the patient. Then comes you have the lower limb. For the lower limb, the lower extremity function is mainly related to the gait. And you have actually you give 0 points if the patient is impossible to walk for the patient. Then if it is patient is able to need cane or aid on a flat ground, even on the flat surface, then you have to give it a 1 point. But if the patient needs a cane to aid, for example, patient can walk without an aid on a flat surface, but to go on the climb the stairs, come down the stairs needs some help, then you give 2 points. But if the patient is possible to walk without cane or aid, but slowly, that is the 3 points. And when the patient is normally walking like any other healthy individual, you give 4 points to it. Then comes the sensory disturbances. Sensory disturbances could be of upper extremity, lower extremity, as well as the trunk. Now, all these are involved. And the last thing which would be included would be the urinary retention. Although that is a very rare sign and late sign, but once that develops, that actually decreases the prognosis as well. You give 0, 1, or 2 points. If there is apparent sensory loss, all the limb is lost, then it's 0 points. If there is minimal sensory loss, only few dermatomes are involved, then it's 1. And if there is no sensory loss, that is 2. Similar case with the lower motor, you have apparent sensory loss as well, which is 0. If it is minimal, it's 1, and if it's no sensory loss, that is 2. For example, if we are talking about the trunk, then usually in the areas, dermatomes of thoracic and these dermatomes, which are upper lumbar and thoracic dermatomes, which are actually supplying the sensory area of the trunk. Usually, if there is apparent sensory loss in these areas, this may be as 0 points. Minimal or no loss, then it's either 1 or 2 points. Now, if you the next is the urinary retention, the bladder function. Bladder function also has basically 4 points, but they start with 0 and progress to 3. There is a complete retention. This is called as, you give 0 points to it. There is severe disturbances. This may lead to 1 point. Mild or normal disturbances. If it's normal, there's no disturbances of urinary retention, then you can give it 3 points. What is important to understand is the less the number of score is, this means the more the severe the disease is. If your points are higher, this means you have a less severe form of a disease. For example, if the patient Japanese Orthopaedic Association score is 10, this means he has quite a bit of a disease as compared to anybody who has, let's suppose, 18 points. Now coming to the differentials of the cervical myelopathy. For any disease, first you have to take history. For example, if a patient presents to you with the signs and symptoms, for example, the symptoms include paresthesias, numbness, fumbling of objects, and with the loss of manual dexterity, with the gait disturbances, you should be expecting the cervical myelopathy. But then you have to perform certain tests to confirm whether this is a problem or not. Usually, cervical myelopathy presents with signs and symptoms of the upper motor neuron lesions as well. There is sensory disturbances, paresthesias, and then there are certain upper motor neuron lesions as well. For example, there may be associated with hyperreflexia, which is very common as compared to cervical myelopathy. There may be an inverted radial reflex. For example, when you create a radial reflex, there's wrist extension without flexion of the fingers. But inverted radial reflex in the patients with cervical myelopathy, they may present with inverted radial reflex, in which once the hammer is done on the brachioradialis, contraction of brachioradialis not only produces the extension of the wrist but the finger flexion as well. This is usually inverted radial reflex. Then there may be other tests as well which may point out towards cervical myelopathy, or which may be helpful in differentiating from other forms of the disease. Like, for example, there may be called as L-Hermite test. Usually L is silent, is called as Hermite test, in which the patient is asked to bend or flex the neck. As he or she just flexes it, she's unable to do it because there is sudden shooting, stabbing pain, like the electric current is flowing towards both of his or her arms. And this is a classically common symptoms with the upper motor neuron lesion as well. Then there is the Hoffman test, which is most commonly performed and actually most pathognomic of cervical myelopathy. Patient is simply sitting on the chair, and classical tapping of the middle finger has been done. And due to upper motor neuron region, there is definitely contractures or usually called as muscular fasciculations, which may be associated with the Hoffman test as well. Then there are certain tests which may be performed to check the gait disturbances. For example, called the heel on the toe gait. The patient is asked to walk on a straight line with its toe pointing in front of the heel, and then again the next foot should be placed in front of the toe as well. This is heel on toe gait. And if the patient has cervical myelopathy, the patient will not be able to perform this heel on toe gait. As for example, this happens in the same case when the patient has alcohol overindulgence or certain other upper motor neuron lesions as well. Then there may be a Romberg sign may be positive as well. Now, Romberg sign is that patient is asked to stand straight with arms forward flexed. Once the arms are forward flexed, patient has to close the eyes, and because the cerebellar tracts are involved, patient is unable to maintain the posture and starts to sway towards the right or the left side. The swaying may be a positive sign for the cerebellar involvement, and especially involvement of the upper neuron lesions, and the cervical myelopathy is just one of the causes of those upper motor neuron lesions as well. So you have to differentiate from certain other diseases because it's actually presenting with its involvement of cervical spine with some form of the upper motor neuron lesions as well. And therefore the differentials includes, the most commonly is the multiple sclerosis, in which there is actually increased sclerosis leading to these kind of symptoms. This could be amyotrophic lateral sclerosis as well, or this could be other causes such as syringomelia. Although usually syringomelia may present with, there is a syrinx which may be present in the cervical canal, if you can appreciate it over here as well. This syrinx may contain CSF fluid, and that may be presenting with these kind of symptoms. There could be associated vitamin B12 deficiency as well, or this could be a simple normal aging process, but this is usually very rare. Other causes could be spinal cord tumors. For example, the patient may be, once we get an MRI, if you see it over here, that may be presenting in the resulting in something else which is compressing from the outside, and may lead to kind of a symptom of cervical myelopathy. Then there may be myelomalacia or cord changes as well, which may be secondary to certain form of trauma, or secondary to certain other causes which may be presenting with cervical myelopathy. So what is the treatment? Once we have taken the history, examination, we have almost formed the differentials, and after getting the x-rays, whether it's AP, lateral, oblique, flexion, extension views, then we get an MRI. Once we've done with MRI, we show that cervical myelopathy. Then what is the treatment? The treatment depends actually upon, it's broadly divided into two types, whether it is non-operative or operative. This conservative treatment includes multiple treatment options, such as, the first and foremost is, it could be simply observation as well. For example, if there is single level disease and it's only slight foraminal stenosis, and there's no lot of muscular symptoms and muscle weakness, there's only sensory disturbances, the patient can be observed as well, because this may be a very early stage of the disease. Other include drugs, such as especially the NSAIDs, anti-inflammatory drugs, as well as physiotherapy. Now, physiotherapy and cervical spine exercises are mainstay of the treatment, especially if there is muscular weakness associated with it. For example, patient may be advised to use hard collar with inside flexion for some period of time, along with the NSAIDs, and once the pain settles down and spinal cord nerve soothes down, patient can be started with aggressive physiotherapy and the stretching exercises of the neck. And other lifestyle modifications. For example, if the problem is associated with certain problems, for example, if the patient has a problem with manual dexterity, or there's a fumbling of the hand, the patient lifestyle can be modified in such a way so that she's able to cope with her activities of daily living. Or if the patient has problems with dexterity, the patient can be advised to use a walking frame, or advised to use a cane or something like that, which actually helps to overcome the problem which he or she is actually facing. Then comes the operative treatment. Operative treatment, there are multiple options, whether from anterior or from the back or from the posterior, but we have certain parameters to decide whether we are going for operative or non-operative treatment. Now the point is, what is important over here is, you need to understand the normal spine anatomy is such that it is actually in a lordotic posture. Now lordosis of the normal cervical spine is very important, but if this cervical myelopathy, the patient may progress into form of kyphosis. So there's an upper limit on which it is actually decided that is 10 degrees or more kyphosis is actually very much problematic, and you have to actually use a different strategy for anyone with more than 10 degrees of kyphosis. Normally 13 degree kyphosis, if it is more than that, it is an absolute contraindication that you should not only go from back, you should also do surgery from the front as well. So why it is important to know that? Because if, for example, this is the cervical spine, it's kyphotic, it's going in. it's already impinging it from the back towards it. And if you do the laminectomy or laminoplasty, which is purely a posterior procedure, it would further aggravate the kyphosis and therefore aggravate the cervical myelopathy. So this is something which you need to understand, that usually the decision is in form of it, whether it's a single level, 1 or 2 level disease, or it's 3 or more than 3 levels disease, and then whether the kyphosis is less than 10 or more than 10. For example, if it's a single level disease and kyphosis is is less than 10, it's a single or 2 level disease, and if it's a kyphosis less than 10, you can simply go for anterior ACDF, anterior corpectomy and decompression with fusion. If it is more than 10 degrees and it's multiple level disease, or it's 3 or more than 3 level disease and the kyphosis of the cervical spine is more than 10 degrees, then you will have to go anterior plus posterior. You will have to do ACDF plus posterior laminectomy or laminoplasty as well. If it is a single level disease and kyphosis is less than 10, you can only go for posterior laminectomy or laminoplasty. But if it is 3 or more than 3 levels, but it's more than 10 degrees, then you may have to combine the anterior plus posterior approach and ACDF along with the posterior laminectomy. So that is important because you have to go for surgical decompression to restore the spinal cord volume, as well as the restoration of lordosis, that you have to correct the kyphotic deformity which has actually been occurring in the cervical spine as well, with stabilization, so that the cervical spine does not further goes into more kyphosis. Now coming to the another disease which is called as the ossification of posterior longitudinal ligament. It is one of the very common disease of the spinal cord and is one of the very common causes of the cervical myelopathy. Now, as you know, when we were discussing the anatomy, there was on the anterior vertebral line you have anterior longitudinal ligament, and over the posterior vertebral line you have posterior longitudinal ligament. It is actually attached on the posterior aspect of the vertebral bodies and comes all the way from the C2 or C1 vertebra all the way back into the L5 or S1 vertebra as well. So if there's ossification or hypertrophy, this may actually impinge on the spinal cord, and this may eventually produce the signs and symptoms of the cervical myelopathy. Now the clinical features. As you know, the clinical features usually resemble the cervical myelopathic symptoms, but the problem is that the diagnosis is very much straightforward, and usually it's of a short time period. It's not such a long time period. There may be axial neck and upper limb pain, classically, which happens with the myelopathy as well. There may be sensory symptoms. For example, there may be dermatomal distribution involving certain dermatomes, or there may be non-dermatomal distribution involving a diffuse type of paresthesias and anesthesias over the upper limb. There may be muscle weakness in the arms. Eventually, it may progress with the muscle weakness once the spinal cord space available for the cord becomes too less, and eventually the nerve starts to degenerate. There may be upper motor neuron symptoms. As I told you, there may be positive Hoffman sign, there may be positive Romberg sign, there may be positive Hamad sign, or there may be inverted reflex as well. All these symptoms of the cervical myelopathy can overlap due to ossification of posterior longitudinal ligament. There may be signs in the lower limb as well. What is important to know is that ossification of posterior longitudinal in the lumbar spine may lead to lumbar stenosis and may present with signs and symptoms of the awkward gait or inability to walk properly. Now, diagnostic criteria is when you get an X-rays on AP, lateral, and oblique views of the cervical spine. Usually, you see there is radiologically on the lateral view, the OPLL is visible on the lateral X-ray, and there may be clinical symptoms which are symptoms of cervical myelopathy. There may be radicular symptoms, and there's cervical spine range and motion abnormality as well. So then certainly you have to go with, on history and examination, you have to perform all the tests of cervical myelopathy, as well as on the radiologically you can appreciate the problems with the lateral X-ray as well. And on the lateral X-ray, you can there may be thickening of the posterior longitudinal ligament, which is called as ossification. There may be calcification, or there may be an hypertrophy as well, which may be leading to this kind of signs and symptoms as well. Now, classification. One form of classifying the OPLL is that if it's continuous form in which this OPLL has hypertrophied right, it extends all the way towards down. This is called as continuous form. It may present with a segmental form that's involving certain segments of the spine, then other segments it may be absolutely normal, and then again presenting in the other segments as a ossification and hypertrophic ligaments. Or it may be mixed type in which there may be segmental as well as continuous type, or there could be circumscribed sporadic type in which there is involving only the single segment, but it's involving circumferentially that whole segment. Not only anteriorly, it's also extending all the way and causing the thickening and hypertrophy anterior longitudinal ligament as well. Therefore, that segment is actually stenosed maximally. Now, once we are suspecting this sort of a OPLL or cervical myelopathy, as I told you, you have to get X-rays on AP, lateral view, oblique views. Flexion extension views may not be required in OPLL, but when we are ruling out other causes of cervical myelopathy, we may require the flexion extension views as well. On the lateral view, if you look closely, this is a lateral X-ray of a cervical spine. There is definitely osteoporosis. There may be an old fracture which may have resulted in the trauma which he or she may have suffered a long time back. But if you see it over here, there is thickening or dense sclerotic lines as well, which is just over at the site of the posterior longitudinal ligament. This thin dense band, which is actually a continuous form of the OPLL or ossification of posterior longitudinal ligament. Now, if you see it over here, this is another diagram in which this is a continuous pattern. Then there are certain segmental areas as well. This is kind of a mixed type pattern in which there is a continuous band in the upper segments, but lower segments may have certain segments may have sparing, and another segments the ossification of PLL may be present as well. For this, you may have to go for laminoplasty or laminectomy as well certain times. But what it is important is that on deciding on the images, this is a CT scan. When you see it over CT scan, you can appreciate how much ossification of this. This is actually a segmental form of OPLL or ossification of posterior longitudinal ligament. This is a mixed form in which there is a continuous, and then there are different segments which are ossifying as well. Now over here, if you see it look closely, you cannot exactly differentiate whether the cervical myelopathy is present or not, but one of the common causes of cervical myelopathy is ossification of posterior longitudinal ligament. So if you see it over here, there's definitely osteoporotic bone. There anteriorly bone spurring as well as some ossified formation. There may be a reduced joint space as well. There is ossification of posterior longitudinal ligament along with the decreased space available for the cord, and that's why patient may usually present with the signs and symptoms of cervical myelopathy. This is another MRI, which is, if you can appreciate it over here, you can appreciate there is actually OPLL ossification which is presenting, and you can look at the cord which is getting tented, and therefore definitely getting compressed over here. But if you see this over here, this is also actually showing there is some form of kyphosis as well and associated cervical myelopathy, because there is definitely a degeneration of these cervical vertebrae. There is actually extrusion of the disc space, there is loss of disc space as well, and there is something which is actually impinging on the anterior longitudinal ligament as well. This is the anterior longitudinal ligament. Look, it's been actually kind of raised, and there is something which is below that. This could be some form of infection, may involving pyogenic vertebral osteomyelitis or tuberculous osteomyelitis. There may be actually the ossification, calcification due to the degeneration, which may be impinging on the this and resulting in actually the classical cervical myelopathic symptoms. Now coming to the treatment. The treatment involves, the mainstay is actually usually initially the conservative form, that is we start with analgesics. The patient can have at least pain-free life, because there are definitely a lot of pain, sensory disturbances and paresthesias. Then the mainstay is actually anti-inflammatory drugs. But now second line drugs have come up, because there's usually with the chronic sign symptoms that there is a lot of recurrence of the ossification of posterior longitudinal ligament. Antidepressant and anticonvulsants may have a role, but although they have in a very small subset of a population, they are actually effective, and usually they're not the first line of the drug. The first line of the drug is actually the analgesics, anti-inflammatory, and opioids. And these are the mainly first line of drugs, but anticonvulsants and antidepressants are getting popular, especially in the very small subset of population which have actually associated depression due to the recurrent or chronicity of the disease. Now coming to the surgical decompression. Now there are three ways in which the surgical decompression can be done, because actually the spinal cord is tenuous, or there is small space available for the cord. Therefore, surgical decompression may be required as well. One way is actually to interbody fusion without decompression. Why we are not decompression but we are just doing the fusion? Because certain types of dynamic cervical myelopathy, in which there is, for example, there is ossification of posterior longitudinal ligament at certain levels. Let's suppose it's at C3, C4 level, and in C5, C6 levels are relatively more mobile as compared to the C3, C4 level. Therefore, during the flexion or extension and certain motions, there will be very small space available for the cord at C3, C4, and then, for example, in extension, there may be more space available for the cord. In these kind of patients in which there is actually dynamic sort of a cervical myelopathy, you can go for the fusion so that the motion is reduced, and therefore when the motion is reduced, there is actually you don't need to decompress and remove the OPLL. Without even removing it and without even decompressing the spinal cord, you are actually reducing the motion, which is actually causing dynamic sort of cervical myelopathy. The other option is to go for anterior corpectomy with or without OPL resection. So what is important again over here is that once we are decompressing is, when we remove the OPL, we are decompressing it. Sometimes the decompression may not be required as well. So what you do is you go in anteriorly and do the corpectomy so that actually the motion is reduced. There's actually fusion of the vertebra, and therefore there is actually the space available sometimes becomes so much that you don't need to resect the OPL. But sometimes, despite if there is some compression, we can go for decompression by removal of the OPLL. The third is, which is option, could be simply all posterior, that is you go for posterior laminectomy or laminoplasty with or without fusion. Depending upon how many levels are involved and whether there is a continuous OPLL or there is segmental involvement, then you can either go for decompression of the OPLL and removal along with the posterior laminectomy, or simply if multiple levels are involved, you may have to go for some form of a fusion as well, so that the cervical spine does not become unstable. We have discussed in this lecture mainly over the cervical myelopathy and one of the most common cause, such as the ossification of posterior longitudinal ligament. We have discussed that what are the signs, symptoms of cervical myelopathy. The patient may present with paresthesias, numbness, fumbling of the object from the hand, loss of manual dexterity, gait disturbances especially, as well as the muscle weakness. This patient may have certain signs, such as there may be associated positive Hermite sign, there may be Hoffman sign may be positive, there may be a Rumberg sign or inverted radial reflex may all be positive as well, and this all should may be associated with usually, for example, if we get an X-rays, there may be associated degenerative changes, there may be facet joint degeneration, there may be bony spurs, or as well as the ossification of posterior longitudinal ligament. Once we have done the history as well as signs, symptoms, then we go on to the X-rays as well as the MRI. Once we have diagnosed it, then we have to decide whether we have to go for conservative management or operative management. In conservative management, the mainstay is actually the physiotherapy, neck exercises, analgesics, anti-inflammatory, and opioids. But once we decide for the surgery, then we have certain parameters whether to go for anteriorly or posteriorly. Then anteriorly, we have option is ACDF, that is the anterior corpectomy, decompression with without fusion. And posteriorly, we have two options, that is posterior laminoplasty or laminectomy. That's all for cervical myelopathy and OPLL. Thank you very much.